they were wonderful. And the plenary was really good this morning. And this one is going to look at the lessons we can learn from the first wave as we're going into the second, and what we can do in the next year. Two quick things. First, if you have any questions or comments, go to the chat function at the bottom and type them in. And when we get time, we will ask that. We'll answer what we can. And I'll ask the panelists also to answer if you can when we're going through. And secondly, it's been because of COVID, and it's always a tough time to fundraise. And so the coalition is in desperate need of money if we can get that. If you could either make a direct donation one time, or preferably if you could make a monthly donation. If you go to the web page, there's a donation box, and you can just click on that and start the process, or we'll send out a link. Amit, I'm hoping that you will be okay to start. Is Amit Arya there? I think I saw.
Absolutely.
Okay, great. Just let me introduce you, Amit. Amit's a palliative care physician in long-term care homes and a board member of the Health Coalition. He has led rapid response teams into long-term care homes during the pandemic and has done so much more than we have time to say here. So I'd like to welcome Amit and kick off this afternoon's panel on what we've learned from the first wave. You're unmuted, Amit. Go ahead.
Yeah, so thanks for having me here. I'm a palliative care physician. I work as a consultant in long-term care homes. And as has been mentioned, I've been on the rapid response teams or on these hospital-led teams in long-term care homes with large-scale COVID-19 outbreaks. And of course, as many of us are learning, there are many, many different things that we can sort of speak about and advocate for in the long-term care sector. So many different changes that are needed, including accountability, transparency, getting for-profits out, and so on. But I just wanted to focus a little bit about what conditions of work determine conditions of care means, right? We often hear that phrase, and that's a very appropriate phrase, when we speak about long-term care facilities. So in my opinion, that speaks to three different things. I mean, that speaks to me about how long-term care is skilled and specialized work. It's work that requires time. And basically that points to obviously how we cannot have, or we should not have one nurse looking after 60 residents at night and 30 in the day, no legislated staffing standard, and PSWs that have no legislation about the minimum number that is required there, and so on. And I'll speak a little bit more today about the physician accountability when it comes to that, and how many sort of residents, should a physician be caring for, and what's safe as well. And also, the third thing would be, we need to build relationships as health workers with the people that we're caring for. Healthcare and medicine is all about relationships, and it should be about continuity of care rather than sort of this rationed and regimented care system that is currently being provided. So once again, I'll say it again, the three things are skilled and specialized work, having enough time and appropriate staffing ratios, along with continuity of care and building relationships. So moving on, I mean, we know that the acuity and complexity of people in long-term care facilities has been rising for about 10 years. We know that I think about 40% of people have 7 or more chronic conditions. The average life expectancy is around 18 months in these long-term care facilities. And, basically half of residents now upon entry have dementia. And of course, as anyone working in these facilities will tell you, this is usually not early stage dementia, but at least moderately advanced or even end stage, dementia as well. And, the basic point that I want to make is that, there's a reason that the specialties of geriatrics and palliative care exist. I mean, the same approaches to healthcare and medicine that work in middle-aged people simply just don't work in seniors, and especially seniors who are very sick, the population in long-term care facilities. I mean, just to give everyone an easy example that we can all relate to, the number one sign of a heart attack in somebody like me would probably be chest pain. But in a senior with dementia who's in their 80s and 90s, you might be surprised to hear this. The number one sign is absolutely not chest pain, but it's delirium. And if someone is not trained on how to recognize those changes, understand, how to evaluate a patient, and by someone, I'm speaking about everyone, the PSW, the nurses, the physicians, the nurse practitioners, social work. I mean, this is all an interprofessional team that's supposed to be there. Well, then you can imagine how that would poorly affect health outcomes on the ground. Recently, I'll give another example. I spoke to, a health worker who was hired by a long-term care facility to provide frontline care. And that health worker, I just don't want to name what profession they're in because it shouldn't look like me as a physician sort of criticizing a particular profession, which is never my intent. But, that health worker actually had 20 years of pediatrics experience and training, and then sort of retrained, not in long-term care, but then just went into like upgraded, their skills, and then suddenly was thrown out on the front lines with no experience, once again, in geriatrics and palliative care, and was calling me for just some help and mentorship, which of course I'm very happy to provide. But, we need to ask ourselves, what really is the standard of care in these homes? And would we allow this in any other healthcare setting? So we wouldn't allow people in the emergency department, right? We wouldn't allow a physician to be there or a nurse to be there without the basic skills in emergency medicine. We wouldn't allow this in the operating theaters, right? If somebody can't do surgery, they can't step foot in the operating theater. And obviously it's a skill for everyone in the operating room, the nurse, the physician, and so on. So why do we allow this in long-term care facilities? We really shouldn't. Now, I know you've been hearing a lot of experts speak throughout the day, so I won't be speaking for too much longer at this point in time. I wanted to address the physician model and how I feel it's working in long-term care. Once again, I'm a consultant, but I've also worked as a most responsible physician or MRP in these homes, and I understand the billing model as well. And obviously I know what's happened with COVID-19. And I think this has been addressed. The physician model absolutely needs to change in these homes, once again, to reflect the skill set where we need to move towards having everyone on the ground trained in geriatrics and palliative care. And one other point about that, you might be surprised to hear that nursing school, for example, has no mandatory rotation education in these fields in geriatrics or palliative care. Neither does medical school. So we're not actually training the health workers to be looking after, the needs of the population and where the needs are, undoubtedly one of the highest, such as in long-term care facilities. So that's an important point. Now, getting back to the physician model, I mean, I'll be very honest, and I hope we all believe this. We cannot have physicians treating this as a side job. We cannot have physicians sort of doing this, on the side of their family practice where they quickly run through all the patients or round on the patients and see an exorbitant number of people, like 150 residents, and then just sort of leave for their family practice and not be accountable. That needs to be addressed. It needs to be called out. There needs to be an enforceable standard of care in these homes. Specifically, I'll even add to that of course, like any other skilled and specialized work, we'll need to build up the workforce, but it's going to take time. And I'll share with you, if I'm caring for residents that have the same level of acuity and complexity as in long-term care, I cannot be seeing 150 hospital or 100 people in or even 100 or 70 in the hospital. That would never be allowed. They would assign me a specific number of patients, which would be, of course, much less than that. So I can be safe and I can also leave at a reasonable time. So obviously that's something that has to change. The billing model also in long-term care is such that basically physicians just get paid a monthly fee for an assessment. It doesn't matter about the quality of the assessment, and all they have to do is they have to do that assessment twice a month. And they paid that like a salary. So that doesn't also set it up so that people are there for a long time and they're providing good quality, evidence-based specialized care. Now with COVID, specifically around physicians, I want to tell you my professional opinion about what happened. Of course, I'll tell you that I saw many homes where the physicians went above and beyond to protect their residents. They increased their hours. They were there like many times a week, or actually I saw one home where the physicians were there every single day, actually rounding on their patients. Some physicians went to a virtual care model, where they were assessing the patients virtually, and there's controversy about that. I wanted to share that what were some of the problems with the first wave in terms of how physician care was handled. Well, of course, there were obvious scenarios, and this was reported in the Toronto Star, in my opinion, underreported. We need to be talking about this much more, where the physicians just didn't even show up. and they kind of abandon the patients. And who's responsible for that, and who is accountable? I mean, I feel the physicians should be accountable. This should be on their professional, like, you know, it should be on their license that they neglected and abandoned the patients. And of course, we know that many long-term care physicians themselves are older. And I can share with you, I know several of them, and they're worried about the COVID-19 virus. But once again, we would not allow abandonment of the patients. My professional obligation is always to do what's in the best interest of the patients and the families, and no one else. If I cannot provide that care, so for example, if I'm an emergency department physician and I can't show up for my emergency department shift because I'm scared for my own safety, I mean, it's not that no one shows up then, right? I have to hand over the patients right away to someone else and put out a cry for help. Or similarly, if I'm a surgeon and I can't show up to the operating theater, that's fine, but then somebody else has to step in and take over. But these physicians honestly continued billing, continued sort of being the most responsible physician without actually meeting that ethical and legal requirement. And that is absolutely outrageous. And it speaks to the bigger standard of care that needs to change in these homes ASAP. So I mean,
one more minute.
Once again, I've spoken about the billing model. And I've spoken about how this is skilled and specialized work. This is not something, I mean, of course, we're all grateful to the military. We're grateful to, you know, the Red Cross now going into these homes. And as an emergency stopgap, as an emergency stopgap measure, maybe that's okay, but that should not be what we're doing in the long term, because it's going to affect sort of the outcomes of the residents. And then I'll add one more last point is that, I mean, a big part of what's happening in these homes, and a crucial role, and my colleague Dr. Stamatopoulos will speak about this, of course, you know, is around supporting the family caregivers, recognizing their essential role in these homes, and also having what we call in medical speak goals of care conversations or advanced care planning conversations, which is something that takes skill and time. I mean, it may take an hour or an hour and a half per resident with each family member, and it needs to be done frequently. So once again, we need the time. We need the skill and the specialized sort of skill set to be available in these homes. And we need to make sure that care is not regimented, where everybody is just getting, you know, their food at the same time. This is not an army barracks, right? This is actually, we're trying to give people a good life in these homes and give them hope, meaning, joy, and purpose. So we need to provide individualized care and have the resources and staff to do that. Thank you.
Great, Amit. Thanks very much. That's for the insights. That's helpful. Thank you. Our next speaker is Dr. Vivian Stamatopoulos. She's an associate teaching professor at the University of Ontario Institute of Technology and is a long-term care researcher and advocate. Vivian, I'm pretty sure you're there somewhere. You're unmuted. If you could go ahead, that would be great. Thanks.
Can everyone hear me?
Yep, hear you just fine.
All right. Hi, everybody. So what did we learn? I was asked to talk about, or what did we learn in respect to our general approach to residents and family caregivers? Not enough. I think what we really saw was how discriminatory and overly punitive our government's approach was to not only seniors in care, but also persons with disabilities, which was, in my opinion, based squarely on a very paternalistic and incomplete medical model that prioritized the risk of viral transmission above all else, above the deadly risks of isolation, which are also, not to mention, morally and ethically repugnant. And all this is to say, you know, this is happening while the rest of society is enjoying a different set of rules and freedoms that effectively allow them to take on different levels of risk, particularly the business community. And for those of you who don't know me, I got into this because I started tracking the government's long-term care pandemic approach after the directive came down, effectively blocking families from the long-term care homes. And I mean, my expertise is in family caregiving, so I study family caregiving, so I knew how hard this would be on families of residents. But I was lucky enough to do my doctorate degree at York University, the Department of Sociology, and I got to learn a lot from Pat and well, Hugh Armstrong's on this call, but Pat Armstrong's like my goddess incarnate when it comes to long-term care expertise. So, you know, I was lucky enough to work on their reimagining long-term care study for my first year as a doctoral student, and I learned a lot there. But it was only until I had my own lived experience with long-term care, particularly over the past year, where I lost a grandmother in not pleasant circumstances in a long-term care facility, and I'm seeking justice as we speak. So, you know, it's personal and professional for me. But I knew the moment that directive came down on March 13th that this would be deadly for residents. And I was also livid on the silence that really occurred the first few months. I felt like I was screaming on an island alone. I mean, I wasn't alone. I remember a handful of people. I remember, Andre Picard had done some stories. Obviously, OHC was talking about it. Nor Laredo was talking about it. There was a handful of people, but I felt like I was alone, and there wasn't enough awareness on how terrible this would be, and not only for residents, but their families. So I started to post, really, I just started to scream on Twitter about how stupid this policy was, and not just stupid, dangerous, unethical, unlawful. And I started to have a lot of families reach out to me, and they started to share their stories of what was happening in these homes in real time. So I started to post a lot of these anonymously, and then people started to pay attention. And then the families that did want to speak up, I would connect them to reporters. So I was, trying to get their voices and their stories out there. That was a lot of my advocacy. This accidental advocacy I kind of got thrown into. And then I started doing my own interviews. I think last night was my 44th interview, and I'm exhausted. But every time our government bungles the response, then I have to talk. Then the phone starts ringing. I wish that everything was running perfectly so I didn't have to talk again. I talked to Amit about this all the time, about how I wish everything just went smoothly so we didn't have to have advocates. But, I saw how this unfolded in real time. From March to June, I mean, it was effectively 3 months of solitary confinement for our seniors. It was atrocious, and not just our seniors, our persons with disabilities in congregate care as well, and retirement housing. And then it took 3 months of screaming to get those outdoor visits. And a lot of that was because, we had a lot of stories starting to come out, and of course the military report that was showing all the terrible things that were happening. So then we got, a crumb thrown to us in terms of outdoor, distance, masked, and time sensitive. So usually half an hour visits per week. And on top of it, to add insult to injury, they were forcing these family members to get tested, which made zero sense. If you know anything about viral transmission, which they should have known since these are the people putting out these directives, Dr. David Williams, it makes no sense under those circumstances to force testing. So more screaming we did, more advocacy, then fast forward another month, we get indoor visits. But really, these indoor visits were literally moving the outdoor visits inside. So you put people at a table in some common room. They were still monitored. There was no privacy, which is a violation of the Long-Term Care Homes Act. And it did nothing to reduce or the negative impacts of those 3-4 months of isolation. I mean, we had families telling me every day how drastically their loved ones had degraded in those previous 4 months. And it was so upsetting for them. What are you going to do? How can you possibly make that better when you're standing across a table screaming to your loved one? Because remember, a lot of these people have vision and hearing issues. So these visits were just completely ill-conceived. And then there was, on top of that, an extended heat wave. And we were saying all along, get us inside. We want to be inside. So finally, September 9th, we get the indoor visitation that we want, but it's still not good enough. You get up to 2 caregivers. So we saw the new creation of this term, caregiver, created, who can now go in during an outbreak. Even still, the problem is we are still hearing inconsistent implementation. I have families up until an hour ago telling me that homes are still coming up with their own punitive policies, making willy-nilly decisions that some residents don't require caregivers, and it's a constant fight all the time. And I think what it really shows is that we just have devalued, well, we know there's been a devaluation of our residents' rights, but especially the value provided by their family caregivers. And this was something that really bothered me as someone that was a family caregiver, and hearing from all of these families who were reaching out to me, and it was heartbreaking and infuriating not being able to help them more. But what they would tell you is that not only was this a violation of their rights, right? So there's the Long-Term Care Homes Act and the Residents' Bill of Rights. And I was very early to write about that back in May, because this was really bothering me that nobody seemed to, really talk about how unlawful this was. And the government just was trampling over these rights that are in the Long-Term Care Homes Act with impunity. But then on top of that, this recognition that visitation is not a nicety, it's life-saving. I want to remind everyone, family are often the first to detect changes in the health of residents. I hear this from families all the time. They're the ones that notice if something is off in the residents, and they're the ones to trigger effectively, medical intervention that often is life-saving or life-altering. So that is suddenly gone. Then we have the fact that family has historically been a very important safeguard against neglect and abuse. I mean, I talked about this last night in an interview that, not to paint the very dismal side of long-term care, but staff-to-resident abuse has increased 148% in the last decade. That's 6 seniors every day in an Ontarian long-term care home being abused, okay? One of the most important roles of family is to be the whistleblower, because we know the staff are in positions often that they're too fearful to speak up. Family are crucial at triggering those ministry inspections, calling the ombudsmen, calling people for help. I mean, if you look at last year alone, the inspection system, 2,800 inspections in total. Only 9 of those were what we call the resident quality inspections that are unannounced and look at the facility as a whole. They're more comprehensive. These are ideal and they should be happening more often. But under our Ford administration, they haven't been. They've been severely decimated. But the remaining pretty much 2,800 minus 9 were critical incident complaints lodged by family. Right? And I've been through this process myself. I was one of these families. So I know how vested interest family have when they're in these facilities to really try to make them better as much as they can. One of the only routes they have is through these processes. Not in there, you can't see what's happening and you can't help. And what this made very clear to me is how we need to entrench these rights in law. And one of the things that think, you know, God, I think she's on this call, NDP MPP Lisa Gretzky, who's just I love her so much. She started here, she was like most MPPs, we're getting a lot of complaints about this. And she reached out to me and we, I just, you know, helped read some things. Really,
another minute, is that okay?
Draft Bill 203. And that is already passed in reading. That bill is designed specifically to entrench the rights of caregivers to access, uninterrupted, continual access all the time, not just in long-term care, but in hospitals, other congregate care settings. And that bill passed a second reading with unanimous consent. So literally, Premier Ford can make that law today if he passes emergency powers to do so. So the question is, why isn't he?
Okay. Thank you very much. I got a lot from the comments. People were really appreciating your comments. It was really interesting. Thank you. Is Mina Suleimankel on?
No, she had a death in her family.
Okay.
I'm sorry. So she's not able to join.
Okay,
that's
that's good.
Yeah.
Well, on to you, Natalie.
Okay.
And then what I would just remind people, again, if you have questions, I think people are doing this very well all by themselves, but just for those who might feel shy, just click on the chat function at the bottom. If you have questions or comments, just type them in and click enter and they'll come up and everyone can see them and we'll ask if we have time at the end. Okay, Natalie, go ahead. I don't know if you need an introduction. I'm not going to introduce you just because everybody knows. Okay, Natalie, go.
Thank you. So everyone is repeating everywhere that COVID-19 has brought into sharp relief the existing inequities in healthcare and in our society. And absolutely, that's true. But it is also at the same time shunted to the back burner and hidden some things that have happened or accelerated in really a very dangerous way through the pandemic, just because there's just the sheer volume of news and because of the crisis in long-term care that has really sort of captured the understanding of media and the public. And so what I wanted to do was cover a little bit about what we've seen as a result of the crisis in long-term care and what we should have learned from the first wave that has not been learned. But also, what does that mean for us as a movement, as a movement to protect public Medicare and to advocate for progressive reform? And then what issues have actually been hidden more because of the pandemic and what we need to do about those? And I'm going to try and do it really quickly. So like in SARS, the inequity within healthcare itself, the really damaging hierarchies, really kind of old-fashioned approach to organizing healthcare has really been shown, although it's really underreported. And so Amit talks about to us, and I love the way he describes it. I'm going to steal it, Amit. In the hospital, when they're donning and doffing PPE, for example, a doctor will be paired with a nurse and they'll scrutinize each other doing it. And they'll make sure that they don't get contaminated while they're donning and doffing PPE. That has never happened in long-term care. Same resident, then patient, moved to hospital, has a completely different standard of infection control and a completely different level of staffing and care. Hospital complex continuing care in hospitals is funded at 3 times the rate of long-term care homes. And yet in many ways, the acuity of the residents are the same as the chronic care or complex continuing care hospital patients. Ditto for, actually it's even worse if you look at psychogeriatric hospital patients, many of whom are now in long-term care, and who were funded at maybe 5 times or more the rate of long-term care residents. And that standard of PPE, even within hospitals itself, has played out. So health professionals who may be taking blood from patients through the entire hospital, COVID hot zones, COVID not hot zones, don't have the same access to PPE that doctors and nurses have. Working class healthcare workers, far less access. When you move from hospitals to long-term care, even in September, the extended care home in Ottawa with the worst outbreak was saying that N95 masks were not recommended for long-term care. I mean, it's just mind-blowing. And when you move to home care, what we've heard in home and community care is from families who are buying the PPE for their own workers going in with no PPE whatsoever. Some go in with gloves, but no mask, never anything above a surgical mask, if that exists. And so in the hierarchy of healthcare, in the hierarchy of class and control in healthcare, you can see very differential access to the basics of infection control. That carries through. It's underreported. It's a lesson that was not learned from SARS, and it's a lesson that continues today from the first wave into the second wave. The second is that it's very clear now that the government is intransigent on staffing. Everything that everyone has talked about, infection control, sequestering, so not isolating, but separating the COVID positive people from the non-COVID positive people, proper care, access for families, all of these require staff. They require enough staff to be able to do it safely. You cannot don and doff PPE between residents if you're a PSW and you even have 10 that you're taking care of in a shift. You absolutely cannot do it, as we've been hearing, at the extended care West End Villa home, when your one PSW has 30 COVID positive residents on the evening shift. Impossible to do. The third thing, and so the government clearly does not want to move on the staffing, has had every opportunity to do it, has even flowed dramatically increased funding for long-term care without actually taking action on the staffing, without attaching strings or doing a big recruitment drive to get the staff in. The lesson has to be this government does not want to regulate staffing in long-term care homes. And that's what we're facing. The priorities over the summer, I think, have also been very instructive. The government prioritized, the first thing they did was bring in a privatization of Home Care Act. That's what they did in the summertime. The second thing they did was to provide funding for long-term care homes that had not come up to the 1999 building standards, provide enriched funding for them to renovate their homes. That funding has been enriched at least 6 times, to my knowledge, since 1999. And the homes are being funded to build these facilities, which are their assets. The majority of them that have C and D beds, the 4-bed to a room types of homes, they're the for-profits, and they haven't done it because they didn't want to spend the money to do it. And there's no requirement for them to do it. And the approach is still voluntary and still to just give them more and more and more good money after bad to do it. The third thing that they did over the summer was develop their new act, which they've just introduced, to indemnify businesses and the government from lawsuits. So to make it a much higher bar that people have to meet and to make it easier to defend. And early on in the pandemic, the first thing that they did was deregulate the only existing staffing standards in long-term care, and we've operated under that all the way through. So the priorities have been to meet, meet the lobbying of the for-profit industry. What they're lobbying for, they get, and what the public, no matter how much it screams about, you know, is lobbying for in the public interest, we are not getting at this point. We've got more funding. In that sense, we've moved the ball down the field, but not in terms of actual regulation. We were able to force a restatement of inspections. The other thing I think that has shown up in long-term care is that the quality of the management is incredibly poor. And in those homes where COVID-19 has spread out of control, what we hear from the workers is admin isn't even on site. They're working from home. They're not endangering themselves. They're nowhere to be seen. That the managements are not out on the floor helping when there's one PSW left. Where is the director of care? Where are the administrative staff? I mean, if people are in unsafe conditions, one would think that the management would get out there and start helping. That is not happening. And that this, this culture in healthcare to do everything to keep people out of hospitals, particularly the elderly, has contributed, I think, to the deaths of hundreds, if not more people in long-term care, because in home after home where 80 people died, you know, 3 were admitted to hospital. You know, people were not given the right to consent, where care wasn't safe. They didn't move them out. And at some point, I mean, you either get staff in there or you move them out of there in an emergency. And that just didn't happen in many parts of the province. There has been a total failure of accountability at every level, at the level of the government, at the level of the ownership and administration of the homes, at all of the levels that we should have had around inspections and compliance and enforcement. But at the same time as long-term care kind of took up all of the attention, what was happening also behind the scenes in hospitals was shunted to the background. Like prior to this, we had fought the hospital capacity issue to the top of the public agenda. It was known everywhere, and that was our work. No one else was doing it. In fact, virtually everyone was against us. All of them buying this kind of nonsense that, you know, we should move people to home and community care and so on. I mean, this is not, these are not transferable services. Home and community care, vitally important, but you're not moving people, you know, closing down small town emergency departments and moving them to home care. And so thousands, literally thousands of what they call ALC patients have been offloaded from hospitals into retirement homes, transitional care units, some of them private for profit, retirement homes, most of them private for profit, hotels, home, often without proper consent and certainly not informed consent, and often to levels of care we don't even know what they are, treating them as though they're some kind of second class of hospital patient that does not have their rights under the Canada Health Act or the Public Hospitals Act wrongfully. It has also rendered home care completely invisible. And, you know, we can't even track the case incidence in home care. I'm sure it's very high of COVID-19. There is no tracking, there's no reporting. There's just no way to even tell the story of what's happened in home care. So I'm just gonna end with one observation about what this means for us. As a movement, I think to win change, fundamental change in long-term care, we have to force a separation between the state, that is the government, and the industry, kind of like the separation between church and state. The same thing for long-term care. There's so much cross-pollination, particularly between the Conservative Party and the for-profit long-term care industry, that it's not just a case of government acting at the behest of an industry. They are the industry. And so far, they have shown that they will not regulate, they will not fine, they will not take licenses away, they will not do anything to hold that industry accountable. And so I think at this point, we need to expose all of those connections. We need to make it politically so costly for them that one, they pay a political price for what's happened. There needs to be a reckoning here. And two, that we force some separation. We need to end for-profit care, there's no question. And we have a chance, I think, with Rivera, particularly at this point. We also have a chance to force the pulling of licenses from these incompetent and negligent homes and start rolling them back in. And for the new beds that have not been allocated, we are gonna have to fight like hell, but we cannot let more be turned over to the for-profit industry. And for our movement, I think we have to agree now that this competition for resources between the community sector and the long-term care sector and the hospital sector has to stop. It has damaged particularly the frail elderly, whose rights actually people were trying to advocate in the first place. Care is a continuum. The entire continuum is needed. This competition for resources is hurting people. And as a movement, we need to advocate for a rebuilding of the continuum of care. That's where I'm going to end. Thank you.
Thank you, Natalie. That's, as always, a very useful summary of where we need to go. We're going to get on to, you can correct me if I'm wrong, Natalie, because the notes, I don't have them. But I think we're going to get on to the action plan for next year soon. Do we have time for a couple of quick questions? Natalie?
We have about 15 to 20 minutes for questions.
Oh, great. Okay. Well, if I can just start. So people have questions, please type them in. But two things that have come up, and maybe if Lisa Gretzky's still on the call, she could answer. There was lots of questions or comments about bills coming towards the House. I was wondering if you could sort of update us on where legislation's at and what you think is likely to happen and what we can do to help.
I don't know if Lisa's on, but well, if she isn't,
she is.
Oh, good.
There you
okay.
are. Lisa, are you willing to do that?
Sure. Hi, folks.
I don't want to put you on the spot, but
that's okay.
It seemed like you would know.
The two, so there's really three key pieces of legislation. So there's what the government has tabled, which protects the long-term care homes from being sued for negligence. And then there's also my bill, Bill 203, the More Than a Visitor Act, which is waiting for the Conservatives to call it its social policy so it could get back in the House for third read. And then on this week coming up on the 28th, Teresa Armstrong, my colleague, is debating Bill 13, the Time to Care Act for, I've lost track of how many times this bill has been before the House. So we need everyone to push to get that not only passed at second reading, but for the government to actually get it through committee back in the House and implemented. So that seems to be the kind of common theme is these bills go to get referred to committee, and then the government, not just the Conservatives, Liberals before them have done it as well. They don't call them at committee. So we really need the push on to get them called at committee and back into the House for a final vote. So those are really the three key pieces of legislation around long-term care that are currently before the House.
Great, thanks, you appreciate that. The other question that's come up a couple of times, and maybe someone could comment on it, is the movement of staff in and out of homes, whether that's gotten any better or worse, or comments on the dangers, I guess. I mean, I think we all understand the dangers, but maybe ways around that too.
Can I just add one thing on the bills?
Sure, yep.
Okay, so Bill 13, the Time to Care Act, is coming up on Wednesday. We put out on Facebook and by email, and we'll send to everyone who's here a list of a link to your local MPP. Can you please send a note or phone to urge them to pass? As I understand it, the Liberals are now supporting that bill. I believe they're supporting that bill, but nonetheless, let's make sure and let's push them to pass. And then as Lisa says, that's second reading, right, for that bill. The fear then is that it goes to, dies at committee and never comes back for third and final reading and passage. That's where Lisa's bill is at. So we'll put something out as well about the More Than Just a Visitor Act, Lisa's bill, and also what you can do about the bill that limits legal liability.
Okay, thank you. So on the sort of little discussions that were going on there on people going in and out of homes, and what steps have been made to either decrease that or control it, whether it's good or bad, whether it's between homes and home care or homes and hospitals or whatever. Does somebody want to take a crack at that? Amit?
I can start, and yeah, I'd be happy to hear from my colleagues Natalie and Dr. Stamatopoulos about how they feel. So of course, in mid-April, there was a directive that was supposed to limit all health work to being in one facility. And we can obviously very easily sort of think about why in a COVID-19 pandemic, how that would be in the best interest of the residents and prevent sort of the spread of COVID-19. So it very quickly came out of the media afterwards that there was this giant loophole where, temporary agency workers can still work in multiple homes. They can still move around. And of course, we know that from the home's perspective, especially a for-profit home, staffing is one of the biggest expenses. So hiring these temporary agency workers is actually better And we know, I mean, obviously we've talked about how their primary interest is not the well-being of the families or the residents, but rather is to make more money and to increase their profits. So that's still going on. The government has no sort of tracking mechanism for that. And it's something that we should be all, you know, really appalled by. I mean, we would never allow this in the school system. Obviously, as we know, in September, there was a big national debate about class sizes, very appropriately, where we wanted to keep our class sizes low. And we wanted to have, you know, people in these learning pods of like 12 kids and one teacher and not moving around. We wouldn't have one teacher moving from school to school, but still in our nursing home system, we can have like, you know, one pod, quote unquote, with 30 people, with one PSW even moving between homes. So and given that the greatest impact of the pandemic, of course, as we know, has been in these nursing home facilities, once again, we should be just so appalled as to how this is still continuing.
Does anybody else want to feed in on that? Okay.
I can jump for a second.
Sure, thanks, Dr. Sarah.
What really bothered me, and a few of us were really critical about that decision, about the giant loophole. And a really important comparison to make is between BC and Ontario. And there's a reason why BC only had 1/10 of the deaths that we did here in Ontario. And a big part of that reason is because they stopped all of that nonsense very early on. After the first outbreak began, they took over the homes, they guaranteed full-time employment, they had no workers going to different facilities, and they just put us to shame in terms of that response. And the government, our government saw what was happening. They knew what BC were doing, and we were warning them, please do this. This is necessary. Stop the interfacility movement, which we know is dangerous. In addition to the fact that ward rooms are still not banned, which is atrocious to me. So our government blocked ward rooms for new admissions to long-term care. But all of those people that are currently in 3 to 4 bedroom ward rooms, which are most often found in the older design standard homes, which tend to also be for-profit homes, they are still in those very dangerous situations. And that was, quite frankly, the question that effectively got Fullerton so angry, she stormed out on the reporter Jessica Cross, who was about to ask that very question, and who highlighted the week before her very damaging flu quote. That was the reason why she was so angry with that journalist, if you missed that whole drama. But there are very clear decisions that have been dangerous and that have been made from the outset that directly impacted to the mortality numbers that we have. And nobody has really, well, reporters have asked these questions, and you just constantly hear the same spin at these press conferences. We inherited a broken system, blah, blah, blah. If I hear that again, I'm going to tear my hair out. But this is the point, is that there's no accountability. Our government knows the decisions that they've been making, and many of them have been overtly negligent, and nothing comes from it. I mean, you just feel like you're banging your head against the wall. Okay, I'll stop there.
Okay, thanks very much. There's a question here, and it says, how are nurse next door? And I'm assuming that what that really means is how are private home care companies or private caregivers regulated as compared to long-term care? Does anybody want to take a crack at answering that? Natalie?
Yeah. So the issue is that the emergency orders, so there are two things. One is that the emergency orders, that is the regulations that the government passed as soon as the emergency was declared, that was March 17th, were to deregulate the existing staffing standards. So the only staffing standard that homes have to have a director of care, they have to have an RN 24/7, they have to have a doctor. So the doctor remains, the director of care remains, the nurse 24/7, the RN 24/7, and that's a 40-bed home or a 400-bed home. That's gone under the emergency orders. And that PSWs in the act that was passed in 2007 were required to actually have go to community college or private college and get a diploma, etc. And there are questions about the wide variation in the curriculum and so on, but they had to have that. They also deregulated that so they could replace PSWs with people that had no training whatsoever. And I saw Katha early on put in the chat that many of the homes, even before this, were replacing PSWs with various aids and things like that. And so what we've seen is sort of within the homes, a deregulation of the existing staffing standards. And this follows years of a shift of the workforce from more nurse to more PSW. Well, the acuity of the residents has really skyrocketed. But in addition, on April 22nd, when the workers had to choose one home to work in, that applied to employees of long-term care homes. It did not apply to agency staff who are not employees of a long-term care home. So those are the differences, the main differences that we see. Other than that, there really are no staffing standards of any sort. That's why we've been calling for a minimum care standard.
Okay. There's two questions.
Sorry, if I can just add one.
Sure, yep, go ahead.
Sorry. I usually don't interrupt, but I just wanted to add one more.
Please do.
That Katha from Unifor has kindly helped to actually correct something that I said, so I'm not spreading misinformation, that agency workers are actually paid more than people working full-time in long-term care. And the reason for that is, once again, related to precariousness of staffing, where there's a revolving door of PSWs. So then we're assuming that because they don't have enough people there, they have to call upon these agency workers. Thank you, Katha.
Obviously, this was an interesting topic. There's tons of comments. I hope there's a way to run off or save the chat, because I think there's a lot of stuff in there that might inform the work of the coalition afterwards. So thanks again. A big hand for me, a virtual hand.